Hello and welcome back. So here I am with the second part of the renal pathology series. फर्स्ट पार्ट में हमने बहुत सारे चीज़ें देखी. We started with the components of nephron. We saw the parts of nephron जिसमें glomerulus, PCT, leukophilidicity, इन सब के बारे में, what are the epithelial cell lining there is, ये सब के बारे में देखा हमने. Then we move forward to the glomerular disease जिसमें हमने glomerular disease को classify किया as primary, secondary. After that we discussed the examples of primary glomerular disease जिसमें हमने nephrotic syndrome, nephritic syndrome, उसके बाद causes of nephrotic syndrome like MCD. We also saw Bush-Pasteur disease, then post-streptococcal glomerulopathy and all this. तो उसी में आगे बढ़ते हुए today we'll be looking into focal segmental glomerulosclerosis. So as the term suggests, focal and segmental. Focal मतलब only some of the glomeruli are involved. अब जैसे मैंने इससे पहले एग्जाम्पल दिया हुआ था while I was telling you about focal, that if there are 100 glomerulus, only some of them are affected, not 100 of them. 100 of them are not affected, but most probably more than 50 of them are affected. Whereas the second term is segmental, it means that it only involves part of glomeruli, not the whole glomeruli, but just a part of it. So going with the term, FSG is characterized by sclerosis that involves only part of the capillary tuft of some of the glomeruli. The part, as we can see, there is only part of the capillary tuft which is involved, justifying the term segmental, and some of the glomeruli are involved, justifying the term focal. Now, how do we classify focal segmental glomerulosclerosis? It is classified into primary, secondary, and hereditary form. Primary is idiopathic. The secondary can be caused by viruses. It can be caused by any drug like NSAIDs. It can be due to SCA or obesity. Hereditary form, it can be autosomal recessive, and mutation is seen in NPHS2 gene. Moving forward with the pathogenesis of focal segmental glomerulosclerosis, the probably primary FSGN it causes are unknown. Injury to the podocyte that are the cell, visceral cell of glomerulus, visceral epithelial cell of glomerulus. The FSGN and MCD, they are a part of continuum, and MCD can transform into FSG. MCD ये कुछ टाइम के बाद ये ट्रांसफॉर्म कर जाता है FSGN में. So that's why we are saying कि MCD and FSGN they are a part of continuum. ये शो करता है the main pathogenesis of this disease is seen that there is effacement of food processes of visceral epithelium. Like if the glomerulus is damaged, the main part which is affected here is the visceral epithelium, and visceral epithelial may be the food processes. There is effacement, or we can say there is damage to the food processes. There is also deposition of hyaline in the glomeruli and entrapment of plasma protein lipid in the foci of injury, which further lead to sclerosis. So the main pathogenesis here is effacement of food process of visceral epithelial or podocyte and the deposition of hyaline in glomeruli, further leading to sclerosis. Now we'll see the difference between clinical presentation of FSGN and MCD. As we read earlier that FSGN and MCD they are a part of continuum, तो इसको differentiate करने के लिए भी we must know, क्योंकि the treatment and the further management plan is different for FSGN and MCD. They both present as nephrotic syndrome. FSGN, hypertension and hematuria is more common, whereas in MCD it is not that common. 50% of FSGN patients they progress to end-stage renal failure within 10 years of diagnosis. If proper treatment is not given to those patients, or they may even require transplant, if these things are not done, then 50% of the patient they may end up as end-stage renal failure. FSGN is more common in adults, whereas MCD, if you remember, it is more common in children. The proteinuria in FSGN is non-selective, that is, it can be albumin or globulin as well, which is secreted in the urine, but MCD it is highly selective. That is, albumin is the major protein which is secreted in MCD, whereas it is non-selective in case of FSGN. There is poor response to corticosteroid therapy in case of FSGN, whereas MCD it responds very well to the corticosteroid therapy. Let's move forward and look into membranoproliferative glomerulonephritis. MPGN, it is thickening of glomerular basement membrane. The second thing which is seen here is proliferation of mesangial cell and leukocyte infiltration. These are the three main characteristics seen here: thickening of glomerular basement membrane, proliferation of mesangial cell, and leukocyte infiltration. As we can see, the glomerular basement membrane, mesangial cell, and these are the major two part affected. So the name mesangiocapillary glomerulonephritis is also used for. Looking into the etiology of the disease, it is primarily idiopathic of two types, type 1, type 2. Type 1 is majorly immune complex deposit, whereas type 2 is dense deposit disease. Type 2, it belongs to a group of disorder which is termed as C3 glomerulopathies. Secondary, it develops in association with systemic disorders. Let's come to the pathogenesis. Here the immune complex ये deposit होता है सब endothelial zone of glomerulus में और further form करता है in situ immune complex against the planted antigen. So this is the pathogenesis of the disease. Immune complex ये सब endothelial and further ये in situ immune complex बनाते हैं against the planted antigen. Clinical features ये adult and young adults and adults में ज़्यादा common है. It presents as nephrotic syndrome. You should know the features of nephrotic syndrome by now. And they have a combined nephritic and nephrotic picture. Disease is slowly progressive, and 50% of the cases, the chances are that they develop into chronic renal failure. Now the morphology. Under light microscope, we can see that the glomeruli, they appear to be large and hypercellular. There is lobular distortion. Thickening of basement membrane of glomerulus is seen, and we have seen that there is subendothelial immune complex deposit. Tubules, there is vacuolation and droplet of hydine is seen there, and in the interstitium, mild focal chronic inflammatory cells are seen. So here we are done with membranoproliferative glomerulonephritis. मेन फीचर जो यहाँ पे याद रखने का है, बेसमेंट मेम्ब्रेन का थिकनिंग, mesangial cell का proliferation and leukocyte infiltration. That's why it is also called mesangiocapillary glomerulonephritis. Etiology primarily idiopathic होता है. Secondarily, it is associated with systemic disorders. Pathogenesis, immune complex deposit in subendothelial zone of glomerulus and in situ immune complex against planted antigen. And you have also seen the clinical features, morphology. So let's move forward to the difference between nephritic and nephrotic syndrome. I think it was not discussed in the first part of the video. Let's see it now. So the nephritic syndrome, the proteinuria seen in nephritic syndrome is 1 to 2 gram per day, whereas in nephrotic syndrome there is massive proteinuria more than 3.5 gram per day. हेमेचूरिया जो है ये नेफ्राइटिक सिंड्रोम में प्रेजेंट होता है. हाइपरटेंशन नेफ्राइटिक सिंड्रोम में प्रेजेंट होता है. हाइपोएल्बिनेमिया हाइपोएल्बुमिनेमिया ये नेफ्रोटिक सिंड्रोम में प्रेजेंट होता है एंड इट इज़ लेस देन 3 ग्राम पर डेसिलीटर. हाइपरलिपिडीमिया, लिपिडूरिया, they are associated with nephrotic. Edema, nephrotic. एजोटेमिया एलिग्यूरिया इज नेफ्राइटिक एंड माइक्रोस्कोपिक यूरिन में हम लोग नेफ्राइटिक सिंड्रोम में आरबीसी एंड आरबीसी कास्ट देख सकते हैं, whereas in nephrotic fatty cast is seen as it is associated with lipidemia. So जो मेन फीचर इसको इस टेबल को इजीली रिटेन और याद करने का तरीका ये है कि जस्ट रिमेंबर द मेजर और द कैरेक्टरिस्टिक फीचर ऑफ नेफ्रोटिक सिंड्रोम which is massive proteinuria, and then there is hypoalbuminemia, generalized edema, and lipiduria. These four are the basic or the most important characteristics of nephrotic syndrome. ये तीन सेट ऑफ फीचर से ही हम लोग नेफ्रोटिक सिंड्रोम को डिफाइन करते हैं. तो दिस थ्री दे आर नॉट सीन और दे आर माइल्डली सीन इन नेफ्राइटिक सिंड्रोम. ओके, ये तो हमारे 4 डिफरेंसेस हो गए. इसके अलावा क्लिनिकल फीचर्स लाइक हेमेचूरिया, हाइपरटेंशन, एजोटेमिया, ओलिग्यूरिया, ये सब नेफ्राइटिक सिंड्रोम में देखने को मिलता है. Diabetic nephropathy, it is a term used for collective lesion which often occur together in diabetic kidney. So there is lesions which are seen in glomerulus of kidney in the case of diabetic patient, and collection of such lesion it ultimately leads to diabetic nephropathy. It can be either insulin dependent type 1 diabetes or type 2 diabetes. We already know about the type of diabetes. Let's look into the pathogenesis of diabetic nephropathy. What actually happens here is that diabetic microangiopathy involves small blood vessels throughout the body. Characteristic of diabetes, which are insulin deficiency, hyperglycemia, metabolic defect, and these all lead to biochemical changes. These biochemical changes, they cause formation of advanced glycation end products, which is formed by binding of glucose to protein non-enzymatically. So what actually happens is glucose binds to the protein non-enzymatically and form advanced end glycation product. These advanced end glycation product, they produce their effect either by direct action or indirect action. The indirect action is seen by binding of AGE to specific receptor. Ultimately, both this pathway, they lead to increased synthesis of extracellular matrix, increased production of reactive oxygen species, and increased direct cross-linking with extracellular matrix protein. These all lead to cross-linking with collagen type 4 in glomerular basement membrane and thickening of glomerular basement membrane, as well as increased mesangial matrix, ultimately causing glomerular hypertrophy, initiation and progression to diabetic glomerulosclerosis. So this was the pathogenesis. If we talk in simple terms, so all these features of diabetes like insulin deficiency, hyperglycemia, and metabolic defect, they cause biochemical changes. These biochemical changes cause glucose to bind to protein non-enzymatically and form advanced end glycation product, which is not seen normally. But in diabetic patients, these advanced end glycation product are formed. They show their effect by 2 actions, direct and indirect. The direct action, the indirect action is by binding to specific receptor. Both of these actions cause increased extracellular matrix synthesis, increased production of reactive oxygen species, and cross-linking with extracellular protein. These all ultimately lead to cross-linking with collagen type 4 in glomerular basement membrane. There is thickening of glomerular basement membrane, increased mesangial matrix, and ultimately glomerular hypertrophy, which cause initiation and progression to diabetic glomerulosclerosis. Now let's see what are the renal changes in diabetes. The main target of diabetes is kidney, the main target organ. The morphology of kidney is seen here. First, we will talk about the glomerular lesion. These are the most important and most common lesions. It includes thickening of capillary. There is diffuse mesangial sclerosis. Sclerosis is seen, and there is nodular glomerulosclerosis, which is also known as kimmelstiel-Wilson disease. We'll see kimmelstiel-Wilson disease here. A bit about it. You can actually get short notes on this topic in your uni papers. So, KYD or kimmelstiel-Wilson disease, it develops in 15 to 30% of diabetic, and it is associated with renal failure. The glomerular lesion which are seen here, it consists of spherical and oval lesion. They are often laminated nodules of mesangial matrix. Situated in periphery of glomerulus, nodules, they are pass positive. If we do per iodic acid skiff test stain, this it's going to be positive. The fibrin caps, they are prominent subendothelial accumulation of hyaline matrix. So there are spherical oval lesions, laminated nodules. There is a peripheral position of these nodules. These nodules are also pass positive, and the prominent subendothelial accumulation of hyaline material. This was all about kimmelstiel-Wilson disease. Just remember few silent features about it. In case you get any question related to it, you'll be able to answer. The second microscopic feature here is renal vascular lesion, which is hyaline atherosclerosis. It involves both efferent and efferent arteriole of glomerulus. It is rare in non-diabetic. The renal atherosclerosis, ultimately it leads to renal ischemia. Now, pyelonephritis and tubular lesion, these are also seen. Pyelonephritis, it is tubular interstitial inflammation of kidney, and it can further also lead to necrotizing papillitis. Just don't really have to remember each and every term, but try to understand this. The next topic we are picking up after diabetic ketoacidosis is pyelonephritis and urinary tract infection. Urinary tract, so let me tell you that we are done with glomerulus. We are moving to the other part of this nephron, that is the tract, actually urinary tract. The most common of them is pyelonephritis and urinary tract infection. Classifying urinary tract infection into lower UTI and pyelonephritis. The lower UTI, it can be cystitis, seen in bladder, and urethritis, or it can be pyelonephritis, which is seen in kidney and collecting duct. So we can see that it is classified based on the part of the kidney which is affected mostly. We'll now learn about pyelonephritis in a bit detail. What actually is pyelonephritis? It is an inflammatory disease of kidney which affect the tubules, interstitium, and renal pelvis. Inflammatory disease of kidney affecting the tubules, interstitium, and renal pelvis. We can see that no glomerulus is affected here. Till now we were learning about glomerular disease, the glomerulopathies and all. Now we have moved to the other part of the nephron. The most common disease of kidney is pyelonephritis. It can be classified into acute and chronic. Acute is caused by bacterial infection, which is associated with UTI, whereas the chronic are more complex disorder. Coming forward to acute pyelonephritis, it is an acute suppurative inflammation of kidney which affect the tubules, interstitium, and renal pelvis. It is an acute suppurative inflammation. It is actually an inflammatory condition. The etiology and pathogenesis of disease we can see in this one simple diagram. Here in this diagram we can see the two kidneys, the renal artery, we can see both the renal artery and renal vein. There is ureter, then there is bladder. So what are the predisposing factors for acute pyelonephritis? It can be chronic cystitis, urolithiasis, recurrent bacterial infection. It can be neurogenic bladder, use of catheter or any other instruments, and BPH, benign prostatic hyperplasia. The most common route of infection is the ascending infection. What happens in this ascending infection is that some bacteria like E. coli and Proteus, they colonize in the urethra. They colonize in the urethra. It can be due to several reasons. After colonization, they may move up and lead to stasis and obstruction. The stasis and obstruction can cause incompetent vesicourethral valve or reflex, seen here in this route. This incompetent valve or reflex will lead to intrarenal reflux of the urine, and also the bacteria may colonize in those pathways. Here we can see the vesicourethral valve. This intrarenal reflex can further lead to bacteremia, spreading of this bacteria into the blood circulation, leading to sepsis and septic emboli. And further homogeneous spread may be seen to other organs. So this was the ascending infection, that bacteria like E. coli, Proteus, ये सब urethra को colonize करके they can further lead to stasis and obstruction of this vesicourethral valve, further moving up in the urethra, further moving up in the ureter, leading to intrarenal reflux and bacteremia along with hematogenous spread. This was about the etiology and pathogenesis. Now let's see the morphology. Gross features which can be seen here are that this acute pyelonephritis, it can be unilateral or bilateral as well. The focal abscess are seen, which are the subcapsular surface, appear small and white. It is most commonly seen in upper and lower pole of the kidney. The pelvic and the calyces, they are hyperemic and covered by purulent exudate. Microscopic features seen here are that interstitium, it shows patchy interstitial neutrophilic infiltration. As I already said that it is an inflammatory condition, neutrophilic infiltration is very common here. The tubules, they can be intratubular aggregate of neutrophil forming abscess, leading to destruction of tubules which are involved and further causing tubular necrosis. In this necrosis and all are only seen in severe cases, whereas the glomeruli, it appears to be normal. The complications associated with acute pyelonephritis are papillary necrosis, pyelonephrosis, and perinephric abscess. Just remember the names, we don't really have to go in detail for now. Clinical features, there can be sudden onset of pain at posturovertebral angle or flank pain, fever, malaise. There can be dysuria, frequency and urgency of urination can be increased. The urinary findings are pus cell, WBC cast, bacteria and hematuria is possible. Pus cell, the urine solely pus, that is pyuria. It is seen in both upper and lower UTI. The WBC cast form, they are only in tubules. Neutrophil indicate renal involvement. Now that we are done with acute pyelonephritis, let's look into chronic pyelonephritis. The chronic pyelonephritis is the chronic inflammation of tubulointerstitial tissue, leading to scarring of calyces, pelvis, and renal parenchyma. It is one of the important cause of end-stage renal disease. The reflux neuropathy or the chronic reflux, which is associated with pyelonephritis, it develops due to superimposition of urinary infection or the congenital vesicourethral reflex and intrarenal reflex. So mostly the intrarenal reflex and the superimposition of this infection, which is seen in urinary tract, This lead to reflux nephropathy. The chronic obstructive pyelonephritis, it can lead to recurrent infection, which are superimposed on obstructive lesion, which are like already obstructed lesions, and further leading to renal inflammation. The morphological changes seen here, the gross feature can be unilateral or bilateral. The size of the kidney is actually reduced due to irregular scarring, scars. They are coarse, well defined, and they are 1 to several in number. The calyces and renal pelvis, it appears thickened and irregular with scarring of mucosal surface. Microscopic features, the interstitium, there is infiltration of chronic inflammatory cell. The chronic inflammatory cell involve the lymphocyte macrophages. The tubules, they show atrophy and hypertrophy or even dilation. So there is thyroidization seen here. What do we mean by thyroidization? The tubules which are dilated, the epithelium, it gets flattened, and they also may get filled with eosinophilic highly material and resemble a colloid containing thyroid follicle. As we remember, do we remember the structure of the thyroid follicle? This thyroid follicle cells, they actually have a eosinophilic hyaline material. When these tubules, they get dilated and the epithelium gets flattened, they somehow resembles the thyroid follicle cells. That's why we say that there is thyroidization of tubules. Coming forward to glomeruli, it is normal. Now that we are done with pyelonephritis, both acute and chronic, I have discussed the major urinary tract infections and the most common ones. There are others as well, but I'm not actually going to discuss them here. But if you have any confusion or want video on any specific topic, please let me know in the comment section. Now we'll discuss the urinary tract obstruction. It can be anywhere in the urinary tract, the obstruction anywhere in the urinary tract. The major cause of this urinary tract obstruction, it can be either structural or functional. Both of them lead to obstruction in the flow of urine. What are the consequences? One consequence which we may expect is infection. The susceptibility to the infection, it increases like rashly, as urine is obstructed in the pathway, it's not coming out of the body. It will ultimately invite bacteria in there, increasing its susceptibility to infection. Also, there are chances of stone formation. The second, on the severe side, we can expect renal dysfunction as well, which mostly or majorly is obstructive nephropathy. Now, coming to hydronephrosis. Hydronephrosis, it is aseptic dilation of renal pelvis or calyces due to obstruction of urinary outflow. It is associated with progressive atrophy of kidney. So in discussion of this urinary tract obstruction only, we come across hydronephrosis. It is a condition which is defined as there is aseptic dilation of renal pelvis. Either there can be dilation of renal pelvis or callus. Ultimately, they will cause obstruction of urinary outflow and progress to atrophy of kidney. Here I have made a small diagram to tell you guys about the causes of obstructive lesion of urinary tract. If you remember this, I hope it will be like easy to understand, and if you draw this same diagram in your exam, you're gonna get full marks too. So starting with the bladder, here is a bladder, and considering the male bladder, we have drawn prostate here too. This is the ureter, the renal pelvis, and this is one kidney. Now we are discussing the causes, starting with the urethra. In urethra, the cause of obstruction can be stricture. If there is any stricture or like there is narrowing down of urethra, this can be one cause of obstruction. In prostate, it can be hyperplasia or carcinoma. See, let me tell you that carcinoma and calculi, they can be cause of obstruction in pretty much anywhere in the pathway. When we finish up this, you'll see this that calculi and tumor are seen in most of the cause, like most common cause of the obstruction. So in prostate, we are very familiar with one condition, benign prostatic hyperplasia. This hyperplasia can lead to obstruction of urine. In bladder, it can be calculi or neurogenic. The neurogenic condition of bladder, like autonomic bladder or autonomous bladder, this all can lead to obstruction. Then in ureter, it can be extrinsic or intrinsic. Intrinsic cause is calculi tumor. Extrinsic cause, like what is not actually happening inside the ureter, but leading to obstruction from the external side. It can be pregnancy where the intra-abdominal pressure increases harshly, or it can be a tumor outside the ureter also. In renal pelvis, it can be calculi or tumor. So this is the diagram. It will help you remember the causes of obstruction easily. Here I have written that in bladder and ureter, the reason it can lead to, in bladder, prostate and urethra, the obstruction can lead to bilateral obstructive disease, and above this ureter, it can lead to unilateral. What do I actually mean by this is that if there is obstruction in urethra here, then both of the kidneys will be affected. Are you getting this? That because there is one bladder only and there are two ureter actually arising from, I have only shown one, but obviously there is one more ureter here. If there is obstruction here, then the effect will be seen in both the kidneys, making it a bilateral cause. Coming to the pathogenesis, it can be seen in 4 steps: obstruction, leading to dilation, leading to decreased GFR, and ultimately causing interstitial inflammation. The obstruction, it can be complete or incomplete. Both of these lead to accumulation of urine proximal to the obstruction. Remember, proximal to the obstruction. This obstruction of pathway, it can lead to its dilation, as even though there is obstruction, but the kidney has not stopped functioning, so the glomerulus is going to continue filtration, and so the glomerulus is actually continuing to filter, but there is obstruction, right? So the urine cannot pass, or there is decrease in outflow of urine, which will ultimately lead to urine accumulation. This accumulation will cause dilation of calyx or pelvis, leading to renal atrophy, compression of vasculature of medulla. Further, it can also cause hypoxic injury to the structures in the medulla. Now that there is urine accumulation, there is no path for the outflow, the GFR will decrease slowly and ultimately leading to interstitial inflammation. There will be inflammatory cell which will infiltrate. This was all about hydronephrosis. Moving to urolithiasis, the second cause of or the second urinary obstructive disease, it is in simple language stone of the kidney. So it may be found anywhere in the urinary tract, but it is mostly seen in the pelvis and calyces of the kidney. Pathogenesis is mainly seen in 2 steps. First is initiation, second is the propagation of stone. Initiation, it starts with the supersaturation of urine. When the urine starts to supersaturate, there is decrease in volume of urine, and there is deficiency in inhibitor of crystal formation in urine, which enhances the precipitation of crystal. So in urine there are many products like uric acid and all those which have this tendency of forming crystal, but in normal state, in a normal healthy person, This is not seen due to the inhibitors of crystal formation. What are these inhibitors? These it can be pyrophosphate, citrate, glycosaminoglycan, and many other things. I have just mentioned three of them here. These are the inhibitors which prevent the formation of crystal in the urine. But if there is deficiency of this inhibitor, you can expect the crystals to form in urine, ultimately decreasing the urine volume and supersaturation, finally causing urolithiasis or the stone. There are different types of urolithiasis or different types of stone seen. First of them is calcium oxalate or calcium phosphate, which is the calcium stone. It can be struvite, that is magnesium, ammonium, and phosphate can be involved. It can be uric acid stone or crystal, can be due to cystine and others. The last and the most important clinical condition of kidney, the malignant tumors of the kidney. It comes under the carcinoma topic. The tumors of the kidney, they are classified by WHO into renal cell tumor, nephroblastic tumor, metanephric tumor, and mesangial tumor. So these are mostly based on the cell which are involved. We're not going to discuss every of them, like all of them in detail, but the renal cell tumor and the Wilms tumor or the nephroplastic tumor are important. The renal cell tumor, it is further classified into clear renal cell carcinoma, papillary RCC, chromophobe, papillary, and carcinoma of collecting duct of Bellini. Now, we'll discuss renal cell tumor in detail. Renal cell carcinoma or RCC. The cell of origin of this tumor is renal tubular epithelium, that is the epithelial cell of the tubules. It can be seen yellow in color. The microscopic resemblance is to the clear cell of adrenal cortex. The age which is mostly affected is 60 to 70 years, that is, it is seen in elderly people. The type, there are two types, sporadic and hereditary. Mostly it is sporadic, that is in 90 to 95% people. Hereditary, it is 4 to 5%. It is a multifocal and bilateral tumor. It occurs in 4 distinct syndromes. There are 4 different syndromes where this RCC can be seen. One of them is von Hippel-Lindau syndrome. It is von Hippel-Lindau. It is actually a gene, VHL gene, which acts as tumor suppression gene. If there is any mutation in this gene, it leads to development of RCC. The other syndrome is hereditary renal myomatosis, hereditary papillary carcinoma, and Bitt-Hogg-Dube syndrome. We need not know in detail about this syndrome, but just remember the names. Now let's classify renal cell carcinoma. I already actually told you the names of the carcinoma involved or classified under this heading. It is clear cell carcinoma, papillary, chromophobe, collecting duct. We'll know a bit in detail about this. The clear cell carcinoma is the most common one. It is usually solitary and unilateral lesion is seen. It can be solid, trabecular, tubular in growth pattern. The shape can be round or polygonal. It can be round or polygonal. The cytoplasm is clear mostly. That's how the name is given, the clear cell carcinoma. The reason behind this clear cytoplasm is that in normal cell there is deposition of glycogen mostly and lipid in the cytoplasm. This cell, when they undergo this process of tissue processing, this glycogen is washed out by the water, solvent, and the other products which are used in tissue processing like alcohol, ethanol, and oil, ultimately leaving the cytoplasm blank or giving it a clear appearance. The second tumor is the papillary tumor. Here the papillary growth pattern is seen as evident with the name. Now the cytoplasm is eosinophilic or basophilic, that is, it is granular. And the important or characteristic feature of this tumor is samoma bodies are seen. These samoma bodies are the characteristic feature of papillary neoplasm. In other papillary neoplasm, like in ovary or other places, we can also see this samoma bodies. Now the third one is the chromophobe renal carcinoma. It is a granular. Here the granular cells are arranged in sheets. Not much to tell about this. Coming to the collecting duct carcinoma. Here the nest of malignant cells are seen. The epithelium, they are highly atypical and hobnail pattern is seen. And talking about clinical feature, patient of renal cell carcinoma, they usually present with a triad of feature which is like characteristic of this RCC. They are hematuria, flank pain or costovertebral angle pain, and palpable abdominal mass. If we see all these features persistent in a person of age 60 to 70 years old, along with one more feature, that is polycythemia, you can like make your diagnosis of renal cell carcinoma. Now, it is like this point is important, so please remember this. The paraneoplastic syndrome, which is produced by RCC, is polycythemia, hypercalcemia, hypertension is there. There can be hepatic dysfunction, feminization or masculinization can be seen, and Cushing syndrome. The polycythemia, talking about polycythemia, in this RCC, there is ectopic production of erythropoietin hormone. You're familiar with erythropoietin hormone, which help in production of RBC. This erythropoietin help in RBC formation. As there is excessive production of this erythropoietin, it leads to polycythemia. This is a very important point. Please remember this. Now let's see the morphological changes. At the site of the tumor, the site of the tumor, it can arise in any part of the kidney, but it most commonly affect the upper pole. The outer surface of the kidney, it appears bosselated, like nodules are seen, and it can even distort the renal outline. Like you may not see a clear bean-shaped organ, but the outline can be a bit distorted. The cut surface is solid and bright. Now the second tumor is the Wilms tumor. It is the nephroblastoma or nephroplastic tumor. It in contraindication to the RCC, it is seen in younger patient, like 2 to 5 year old children. It is more common. The most common primary renal tumor of childhood. It is highly malignant primary embryonal tissue. The pathogenesis can be sporadic and unilateral. There is mutation seen in tumor suppressor gene, which is WT1 and WT2, that is Wilms tumor 1 and Wilms tumor 2. Mutation in these genes can lead to Wilms tumor. Gross feature, it is the kidney appear large, or the tumor we are talking about. Tumor is large, single, round. It can be well circumscribed mass. It is usually unilateral. The cut section of the kidney is soft, bulging, and homogeneous mass appears tan to gray in color. So single, large, round, well circumscribed mass, usually unilateral, cut section so soft, bulging, homogeneous mass, gray to tan color. Microscopic feature is again very important here. Here it present as triphasic combination. The tumor has three major components, resemble normal fetal tissue, the cell attempt to recapitulate different stages of nephrogenesis. Nephrogenesis, the process of formation of nephrons. Here, the tumor cell, they attempt to recapitulate these different stages. The three types of cell here are differing to the triphasic combination are blastomal component, the immature stromal component, and the epithelial component. The blastomal component, they are small, can be round or oval. These are the blue cell with scanty cytoplasm. So if you see the microscopy of this Wilms tumor, we can see small, round, oval, blue with scanty cytoplasm cell. These cells are blastomal cells. Now the second component is the immature stromal or mesenchymal component. They have undifferentiated fibroblasts like spindle cells. So spindle cell are there, myxoid tissues are there, and these are undifferentiated fibroblasts. And the third and the last one are the immature epithelial component. These are the three type of cells seen: blastomal component, immature stromal, and immature epithelial cell. With this, we are done with Wilms tumor and we are also done with renal pathology. Thank you for being so patient and watching the video till here. I hope you really learned something and this video helped you.